Hi, I'm Brian Stetton. I'm the Policy Director for the Treatment Advocacy Center, and we're doing one of our Skype chats with AOT implementers around the country. Today we have Dr. LaTricia Coffey, who's the Medical Director for the AOT program in Clark County, Nevada. That's Las Vegas, operated by Southern Nevada Adult Mental Health Services. Dr. Coffey, thank you so much for joining us.
Thank you for inviting me.
Great. So why don't you start by just telling us a little about the AOT program that you're operating there, when it started, how far you guys have gotten with it, in terms of how many people you have in the program now, and whether you've been able to graduate anybody from it.
Certainly. So our program actually began just approximately 2 years ago. The fight to begin our program began 6 years ago, and after 4 years of a battle, they were finally able to get it up and running and authorized. So for about 2 years, we've had a program and a full staff, and been bringing in patients. We've been graduating them. In that time frame, we've had approximately 150 patients. Bearing in mind the way that our program works is very closely with the court system that was part of the motivation for the legislators to get it passed. So we continue that relationship. So they have a lot of interaction with us in terms of how many patients. So we didn't start off and fill our roster immediately, even though we could have. We started off with a maximum number of patients, and then we increased that maximum number to now we run at about 75, right between 70 and 75.
Gotcha. And are you generally using it as people are coming out of the hospital as sort of a way to get them back into the community with enough support?
That is how we use it. I understand from my research and talking to other people that there are a couple of different ways that it's utilized, and the way that we're utilizing it, the way that I think makes the most sense, is not taking people that necessarily meet full criteria for being inpatient, but people who are coming out of inpatient and
now meet this
step down
standard. Yeah.
And we are able to, because the biggest difficulty with many of these patients is not that they can't get stabilized, it's that they can't maintain stabilization. And so we are there to fill in that gap and help keep them from falling off the wagon instead of going to find them and putting them back on the wagon.
Right. And describe your role with the program.
So I am the psychiatrist. I'm the senior psychiatrist in the program. Our program initially began with a psychologist and several social workers, a nurse, and a psychiatrist was not on board yet. Over time, we've evolved the positions and sort of figured out what needed to happen. We've identified that the medical aspect is actually very, very important. So one of the struggles, not really a struggle, but a challenge is in figuring out, is this more of a social services program or is this a medical clinic? And as a medical doctor, I obviously see it. It is a medical clinic with a tremendous social services department. So
you're using social services to fill a medical need.
Absolutely. I can order all of the 3-month injections I want, but without my social service team, it's not going to happen. So I don't directly oversee the social workers and the case managers. I work very closely with the young lady that does oversee them, but I do sort of supervise the entire program in terms of making sure things are where they should be, where we want them to be.
Right. And are you performing evaluations of the patients as a psychiatrist to determine whether they meet criteria? Is that part of your role?
So currently, no, and that is an evolving position. That's one of the things that we're working on, trying to look at what other programs do and decide what's the best approach. We have been using the young lady I mentioned, who is a social worker by training and is in charge of the caseworkers and the social workers, because obviously she's got excellent insight and knows what's going to be happening on the ground more than I do. However, we found, as most programs have, I believe, over time, if you don't, upon your initial assessment, look at the medical component and look at some of those things, some of those medical, physical things that impact the social services aspect, if you don't look at those things up front, you can end up with some things that can make it difficult. So we're going to combine that. We're working on combining that assessment so that there's a medical aspect and also a social services aspect. So right now, I don't do the assessments of bringing people into the program.
Gotcha. But I imagine some psychiatrist has to perform an evaluation and say this person meets criteria and then appear in court to testify to that, right?
Absolutely. So our program is, and I only recently discovered the nuances, our program runs like several others do, in that the initial assessment by the court for if a person meets criteria for commitment in the state is
Yeah.
a singular assessment. So it's sort of viewed as that assessment when a person is definitely seen by two psychiatrists
Right.
and the court system, and they are committed to the system. The first step of that commitment is inpatient. So the second step, when they're stepping down to our program, the way that our statute is written does not require an additional assessment because we're stepping them down.
Right.
We haven't ended the commitment. We've just restructured it. So there's not an additional new assessment.
So upon their release from the hospital, then will they see a judge? Will they be told, we're now changing your commitment to an outpatient type?
Absolutely.
And here are the expectations of you?
That's correct. Our team goes in and they meet the person before they leave at least once, hopefully twice, to discuss it with them and to see if they're appropriate, the whole process, but also to get their input. What do you think about this? Do you want to do it?
Sure.
Then they go to court, which may be via video or in person, however that happens. The judge asks them, do you want to be in the program? This is what it's going to be for. The person may say yes, and they may say no, and the judge makes his decision. So the person absolutely is always there. That's actually a recent modification we've made, because we work so very closely with the court system. We both agreed that we want to step up the patient's involvement. So we really, really are insisting that they are present for those.
Right. And I imagine you're getting the patient engaged in developing the treatment plan too, to find out what their preferences are and you know, what kind of treatment they're looking for.
Absolutely. Actually, a large portion of that is done during the initial assessment. So when an inpatient person says, we've got a person who needs to be an AOT, we don't just go over there and look at them. We go over there and we develop a treatment plan, because our petition to the court is the treatment plan. So we look at what their needs are. We discuss with them. Do you need housing? Do you need money? Do you need food? We present all of that to the court. And the court has the opportunity to ask the patient, do you really need this or not?
Yeah. So now at this hearing that takes place, I imagine it happens a lot of times in the hospital, right? You've got a hearing room of some kind in the hospital. So at the hearing that takes place upon the person's release from the hospital, now we're changing them to an outpatient commitment environment. Will a psychiatrist appear at that hearing?
No, a psychiatrist is not required to appear at that hearing currently because they've already been assessed by a psychiatrist. But no, so that I have tried to attend. I think it's a good idea to attend, but because we have a good support system there. So the young lady I've mentioned again and again that coordinates our service coordinators is there every time. And the person's assigned service coordinator is there, and the person is there. So medically, there's not a lot of medical input into that decision. So I don't attend.
Okay. So when folks are out in the community on these outpatient commitments, do you have interaction with the patients personally?
Absolutely. So once they're in the program, they've left the hospital, and you're saying that they're living now out in the community? Absolutely. So we see them like any other patient in terms of we schedule an appointment, we expect them to be there. The same, except for there's a lot higher level of intensity in that we keep a very close eye on their absences. We inquire much more about their everyday activity. Are they taking medication? We've established a system, and it'll be individual for every program. What number of days of medication refusals is enough to intervene?
Right.
And then we decided that we needed to do that because we've got some who they could miss a week and be fine and get right back up. We've got some that if they miss a dose, and I can only know that, only me or my nurse can know that, or someone acting in that role. So we go out there, we will count the pill bottles and the pills and look at the labels. I do that on a regular basis. Right,
which is, I'm sure, a reason you prefer the long-acting injectables, to just take that out of the equation for everybody, make it easy.
You know, I'm still developing an opinion on that, but one of the great things about this program, it's a controlled, structured setting in which to develop a really comprehensive opinion. So I can look at it medically. I can look at the patient and almost see when it's reaching kind of a therapeutic plateau. And I can also find out from the patient, how do you really feel about this? It's been a month now. It's been 3 months now. How does this compare? You used to see me every week. I used to come to your home and look for you. Now you only have to see me every 3 months. I'm just going to bring you back sometimes just to tell you how great you're doing.
Yeah, I'm sure that They feel a sense of accomplishment when they reach that point.
Absolutely.
Yeah.
And without that,
It's all about.
that's what it's all about. Without that joy,
Yeah.
they wouldn't come back.
Yeah. So let me ask you about the issue of insight, because at the Treatment Advocacy Center, as we promote the concept of AOT, we often explain to people that this is primarily targeted at individuals who struggle with insight, who have anosognosia in many cases, and don't necessarily understand they have an illness or need to take medication for it. But of course, that's never in any state part of the actual criteria, right? You're looking for people who have a history of struggling with medication compliance for whatever reason. But we have certainly heard elsewhere that anecdotally, that often is because of a lack of insight. So I'm curious what your experience is with your patients. Do you find that anosognosia or lack of insight is a common feature of the people who wind up under AOT in Las Vegas?
I find that there is certainly a subset. It's a small subset for whom there is almost no insight. There's none. And then there's a larger population for whom, and I think this is the majority, for whom insight waxes and wanes. And that's the difficulty. It's kind of like a doctor determining capacity as opposed to determining competence.
Right.
It changes almost moment to moment sometimes. My personal opinion, and this is just based on my experience and my investigations and reading the literature, is that if a person has a circumstance which renders them of zero insight, it's not something that they are capable of forming, either due to brain damage or severe drug use as the primary issue, or whatever it is that impacts the area of the brain that affects the actual ability to have insight. I don't believe those are good candidates for AOT, given the limited resources. I think they are excellent candidates for resources. I think they are excellent candidates for help. The majority of them that I've seen in my program, those people that have the zero insight, haven't refused help over and over again. They either haven't understood that there was help, or they haven't. If they can't recognize illness, they can't recognize help or the need for help. And so those people need what we do, but it doesn't necessarily have to come along with the limitation of freedom and civil rights that some people feel comes along with AOT, because that restriction comes with many, many, many motivating factors. And so you balance out, is it effective? Is it so restrictive that you're damaging the person, or is it just restrictive enough that you're lifting their level of insight and motivation just where it needs to be? With the zero insight, a court order does not provide them any insight.
Right. So the black robe effect, then, you think is not going to be effective for somebody who is certain that they don't have an illness, they don't need medication, and they just don't want any part of this. You think they're just going to take a hike, whatever court tells them to do.
For a large portion of those people.
Right.
The majority of those people.
Right. Interesting. So the people who you do put in your program, then, as you say, they tend to be more individuals for whom insight is, they have sort of a tenuous grasp on it. They may have it at the moment they start. So as you're transitioning people out of the hospital, I imagine they're in a pretty good place at that moment, right? They do understand that their lives will be better if they adhere to a treatment plan.
To some degree. They do understand at least that one aspect will be better, and that might be just the aspect of not going back to court or to the hospital. Right. So there's a small population that only understand that aspect, but a much larger population understand that there's a chance that all of those things they said could actually happen, and things could actually get better for me if they happen. And they do, because we make them happen. Yeah.
So are the patients at the beginning of the process, do they tend to be annoyed with you or resentful of you in a way that maybe interferes with the doctor-patient relationship?
Surprisingly, no. And I shouldn't say surprisingly, because I've been doing, psychiatry and medicine forever. And so this is not a new phenomenon, but almost like back when you're first a medical student, when you go in, you're hesitant to ask these intrusive questions or to do a variety of things that you're certain is going to turn your patient off. And it absolutely does the opposite. If you do not ask your patient if they're suicidal because you're afraid to bring it up, you won't get the answer. And when you do bring it up, they almost embrace it. And it's the same thing with the program. If you don't approach that, how does it feel? You're kind of in this program against your will, kind of. If you don't bring it up, you're actually more likely to engender this sort of reluctance, me versus them kind of approach. So they may be a little apprehensive. And again, my own personal experience, and this is just my personal experience, is I personally reiterate the program and the logistical aspect of the program so that my social workers and my nurses do not have to. So I talk to them about the court order.
You play the heavy, in other words.
I am the heavy, and I'm okay with it. So
Yeah.
I say the court order. I do all of that. And I tell the families and I tell the patient, you can get super mad at me, and I think you should pick up the phone and call that caseworker of yours and tell them exactly what you think about me. At that point, we've made progress because they're contacting a caseworker.
Yeah.
And they're talking about a legitimate feeling, and they're able to express it with some clear language, and it's not their mental illness that's the issue right now.
Right.
These are two adults having a disagreement about what should happen.
Gotcha.
That gives them respect. That makes them feel part of the process, even though it seems counterintuitive. By kind of being the heavy and opposing them just a little bit with reality, they actually feel more empowered and more part of the process instead of you're here and you have to do what we say and that's it.
Yeah, that's fascinating. It makes a lot of sense. And how does the relationship evolve over time, do you find? Does things sort of calm down as you go through the months of an AOT order?
Yes, almost invariably. I will say part of that is going to have to do with the physician that is involved, because I kind of think of this the way that psychiatrists tend to think of substance abuse treatment. Everyone cannot be a substance abuse treater. It's not for everyone in any way. There are certain personality types, certain levels of patience, certain parameters that you're looking for. And if yours is kind of the typical parameters of improvement, you're going to be frustrated because you're not going to see those manifest in the same way. Your patient's not going to know what you're talking about. So you have to be willing to have that kind of flexibility and recognize that patient A coming in every week to yell at me is a parameter for improvement, because I don't have to go get patient A from under a bridge anymore. And patient A coming in and saying, Dr. Coffey, this is why I'm not going to talk to you. I know things were good last week, but I'm mad at you this week because I didn't get my money, which I have nothing to do with. That's perfectly fine, because she's not mad at her caseworker. And I say, I tell you what, you don't have to talk to me today because you're mad about that money. Why don't you go in there and talk to my nurse, get your shot, and get out of here. If you're mad, you shouldn't be in the place that's making you angry.
Yeah.
Go get your shot and get out of here. Come back next week and we'll talk about it. We'll see if you've gotten your money worked out. I will tell that caseworker you want your money. And so it's a short visit, and sometimes it might not even qualify as a visit. But I've directed them somewhere. They're not under a bridge. They're not in jail. They haven't torn up my wall or my buildings, or the things that traditionally have gotten them in trouble. So it does evolve to where they can tell me how they feel. They're not afraid anymore. Sometimes they almost forget it's kind of a coercive environment. They almost forget the court order exists.
Yeah, which is what you want.
That's what you want.
Sure, because at some point they're going to have to sort of graduate from the program and fly without it. And,
absolutely. We run across an occasional one that says, as soon as this program's over, I'm quitting all this. But it is occasional, and it goes back to what we said earlier. That is a person that may not have been a good candidate in the first place. Yeah. But the I would say overwhelming majority throughout the time, they don't feel coerced. They may feel a little, well, I want to live in a different apartment. When I get out of AOT, I want you to move me to a different apartment, which is a huge leap. Because for the others, it's as soon as I'm done with this program, I'm out of here and I'm going to live wherever I want. I'm never going to call you again. So that subtle difference is, when I get out of this program, I'm going to call you to help me find another place. Right.
In other words, they're telling you, I'm going to stay in services.
They don't even realize they're doing it, but absolutely.
Right. Yeah, interesting. So when you do find that someone is doing well during the term of the order, but they're basically telling you explicitly, when this is over, I'm done with this, and I would think that would give you reason to think that maybe the order should be renewed. I mean, does that lead to you seeking a renewal of the order when you get to the end of the term because you feel like the order is the only thing standing between them and their old habits?
To some degree. So
Yeah.
I would say for me, almost certainly at least the first renewal. And part of that has to do with my knowledge and understanding about what the literature says about the extended improvement, the sustained improvement, and that sustained improvement that the literature cites is not after 6 months of commitment. It's after a longer time of commitment usually. So the longer that they're in, up to a certain point, they're able to sustain improvement longer. So
Right.
the fact that they are able to say within 6 months that I'm not going to X, Y, and Z, part of it has to do with why, what their motivation for saying that is.
Yeah.
If they're saying it and they're currently non-compliant and not participating, that's different than if they're saying it and actively compliant and actively participating, because that
Right.
is who the program was made for.
Sure.
They are
Sure.
able to comply. They are able to participate. They just don't want to.
Hmm.
And so that's where the power of my team really, really comes in.
Yeah.
In traditional medicine, you're really not to talk your patients into things.
Yeah.
You're to give them your advice, what you think,
Right.
et cetera,
Right.
et cetera.
Right.
This program leans a little teeny bit away from that, in that we as a whole do encourage them that they should be compliant. They really, really should
Sure.
participate. And the
Yeah.
worst case scenario, if you don't, not just will you get in trouble, that's actually the least of it. If you don't, bad things are likely to happen to you. Tell me
And of
your
course,
plan for maintaining whatever it is after you get away from us. Sometimes, occasionally, they actually have a plan. They have a legitimate plan that could reasonably work.
Mhm.
But for the majority of the time, at the end of that 6 months, they've almost always budged a little bit, unless substance abuse is their primary diagnosis,
Yeah.
or unless they've got really a significant amount of brain injury. And again, perhaps neither of those should have been here in the first place.
Sure. So your statute then limits the term of the order to 6 months, is that right?
The initial order is 6 months.
Right. And so roughly, how frequently would you say those are renewed at the end of that 6 months?
Oh, a good 75%.
Okay,
if
interesting.
not a little bit higher.
Right.
And part of the
more than
rationale
6 months.
here
So,
is that first couple of months, we're adjusting. We're really getting used to them. They're getting used to us. Our particular program, we may get patients that have been in another city in Reno in the forensic psychiatric hospital for years, months, whatever. And
Right.
their first leap outside of that hospital is straight to my clinic. So they're meeting a caseworker they've never met or heard of, because in those circumstances, we haven't gone up to Reno and seen them yet.
Yeah.
So a caseworker they've never met, a building they've never been to, a doctor they've never met, and we're strangers finding them a place to live that they don't know anything about. So
the state hospital is up in Reno. People are coming back from
the
there.
forensic state hospitals.
Forensic state hospital. Okay.
And so occasionally, because all the programs are kind of grappling with where we're connected with the forensic programs, and I try to be very, very clear on those lines.
Yeah.
We're not an alternative to criminal assessment, adjudication, but we can assist. So those types of clients, and there's a fair number of people coming out of either our judicial system or up there in Reno who we're new. This whole thing is new to them. So the first 3 months might just be not getting you kicked out of a place. And for certain patients who will say, well, I'm not coming up to that clinic 3 times in a week to meet a doctor one time, an injection another time, and a social worker another time. Depending on that client, very individualized. I might say you can skip the doc appointment this week because you have to meet that caseworker because you've got to get a place to live.
Right.
Then I can come see you at your house. But you can come see me and get a prescription, but if you're on the street or back in jail, my prescription is useless. But if you get in and spend that first couple of months, maybe getting kicked out of a place or two, maybe kind of battling back and forth if you want to do this or not, right around the 3 months, you're kind of settling in. So as they start to get better, there's a brief period of still limited insight.
Yeah.
Am I better? I'm not really better. If I am better, it's not because of you. And then around
That's the plan, right?
around month 4, 5, 6, you start getting some acknowledgement.
Yeah.
That, okay, I am better.
Yeah.
but I'm not sure why I'm better. And so now you're around maybe month 8 or 10 before you get a real buy-in.
Mm.
I'm better. It's related to this program and it's related to that court order. And
Wow.
it's not killing me. It's not hurting me. And it's
Yeah.
actually kind of becoming a way of being, not just a thing I have to do. And I
Mm.
actually kind of like it.
So given that time frame you're describing, I'm curious, do you think it would be an improvement in the Nevada law for the initial term to be extended to, say, up to a year so that you could, it seems like, if I'm hearing you right, that it pretty typically takes more than 6 months for that level of understanding to kick in. So, would the law make more sense in your eyes if it allowed you to have an initial term of say, 12 months?
Despite what I just said,
Yeah.
I'm going to sort of say no, and here's why. I'm a forensic psychiatrist as well, so I'm very particular about laws and rights and legal
Yeah.
representation, et cetera, et cetera.
Yeah.
My hesitation is that given a year, because it's a system, it's not just me and my patient, it's a system.
Right.
There are other elements of any system that could just sort of say, well, we've got a year. So we're not going to try to move things
Mm.
along. We're not going to necessarily be as motivated to, go as quickly as we can because we've got a year.
Right.
So I
Right.
think actually, so even though I know what I just said, I actually think right at the 6-month mark forces a reassessment.
That makes actually perfect sense to me because, we always say that AOT is not just about committing the patient to the system. It's also about committing the system to the patient, lighting a fire under service providers of various kinds. Know that the court is paying attention to this case and is going to have a hearing in a few months and is going to want to see some progress. So I think what you're saying really speaks to that side of the equation.
Absolutely. And I probably make that statement once a week. I might have gotten that from you. When you've
That's
got
fine.
that reluctant patient who says, oh, well,
Yeah.
I don't want to, and I really, really have pulled out all the stops,
Right.
I will say, well, so listen, I need you to help me out because I'm responsible. I have to answer to someone if
Yeah.
I'm not getting you better. So
Mhm.
give me a reason, give me something I can tell the judge. And sometimes they do. Sometimes they don't. But it is that, and you'd like to think that people don't require being lit, but they do. That's human nature. We do.
Sure.
And
Of
so
course.
at that 5-month mark, everyone starts rushing in with, this is what I think about so and so. And I've gotten to where my team has come to know what I look for. I don't
Yeah.
just sign a paper. If you bring me a form that says we haven't seen John in 3 months, termination, that's not something that I'm going to sign. We haven't seen John. We've looked for him 3 times. We've been to the jails, the hospitals. We've enlisted Metropolitan Police Department's help. We've contacted his family. He's not in the places that he normally is. We've sent a certified letter, and it's been 3 months. Then that might be appropriate, but not just we haven't seen him, because we've got
Right.
some patients. I've got a gentleman that has toothpaste in his hair on a regular basis that we might not see for 3 months, but he's fine. He's got toothpaste in his hair, but he's okay. He's
Right. Still being monitored by the team,
infinitely better.
on the radar, and that's a whole lot better than him not being on AOT at all and off the radar.
Absolutely. Infinitely
Yeah.
better. So he may only show up every 3 months, which is technically non-compliance, but that's why it's very individualized. It requires
Right.
a lot of flexibility in thinking.
Well, it's really interesting and fascinating, and we could go on longer, but I don't want to make these videos too long. So I really thank you so much for sharing your insights. And I just remind anybody watching this, if this raises any questions for you and you have questions for Dr. Coffey, funnel them through me. I'll be happy to get you answers.
Absolutely.
And thank you so much for all you guys are doing in Las Vegas, and hope to talk to you again soon in the future.
Thank you for your constant help. We'll keep in touch.
Absolutely. Take care.
Bye-bye.